Single, thank you so much for that introduction. Etna, it is a great privilege and honor to be with you today, even if it's by Skype. I would far prefer it in person. Thank you very much for this wonderful award and this beautiful word. We are going to today the management of endophthalmitis surgery. I will discuss also silicone oil for endophthalmitis.
Dr. Flynn,
Yes.
we can't hear you well. Is it possible to be closer to the microphone or to...
Yes.
Yeah, it's better now. Thank you.
Perhaps they could turn the volume up a little bit on the audio.
They can't turn the volume up. If you can come closer to the microphone and speak louder, Harry. Sorry.
Okay. Can you hear me now?
Very well.
Yes.
Very well.
Okay. Next slide, please. Everyone here knows Relja Zivojnovic. I met Relja back in the early 1980s when I was very early on the staff at Bascom Palmer, and I was so impressed with his surgical skills and also with his humility to talk with everyone and explain his techniques and to help us in our careers. His background is well known to everyone here today. He was born in Austria, grew up in Serbia, and then ultimately did his training in Rotterdam. He became one of the leading vitreoretinal surgeons throughout the world and was a teacher to many of us here in the room today. I greatly admired his surgical techniques and his ability to take the most advanced and difficult cases and restore vision and accomplish amazing vitreoretinal surgery. In addition, he was an innovator of multiple instruments and had wonderful video recording of his surgical technique. So I salute Dr. Zivojnovic as a friend and mentor to many of us here today. Next slide, please. Endophthalmitis can be classified into various etiologies. These include postoperative, post-traumatic, keratitis-related, intravitreal injection-related, and endogenous. Next slide. Some examples are shown in this slide. The unifying features include marked conjunctival congestion, hypopion, vitritis, and a profound loss of vision. Next slide, please. What about vitrectomy? Vitrectomy is typically reserved for the more advanced cases. The benefits of vitrectomy are well known to everyone in this room, and they include the reduction of the microbial load and toxins, removal of vitreous membranes, obtaining an abundant sample for culture, improved visualization of the posterior segment. The disadvantages of vitrectomy include the need for specialized equipment and support staff, as well as operating room setting, anesthesia-related risks, and difficulty due to opacities in the media. Next slide, please. The endophthalmitis vitrectomy study was conducted in 1990 through 1994. It randomized patients to either an initial cap and inject versus vitrectomy or systemic antibiotics versus no systemic antibiotic. Next slide. The result of this study is well known to everyone here. For patients with hand motion or better acuity, there was no difference in the final acuity outcome between vitrectomy and cap and inject. However, if patients have right perception visual acuity at the initial presentation, vitrectomy had much better outcomes. 3 times greater outcome were better, 2 times greater outcome with 100 or better, a 50% reduction in rate of less than 5 visual acuity. Next slide, please. However, this study did not conclude that vitrectomy is contraindicated for eyes with better than or equal hand-made acuity. Today, I continue to use vitrectomy in more advanced cases, and I'm not restricted by this study and this result. Next slide, please. Today, we have small gauge vitrectomy. We have the advantage in an eye with conjunctival compression of being able to avoid bleeding from the conjunctiva, avoid problems with sternotomy sites, able to perform a quick and simple vitrectomy. Because many patients have congested conjunctiva, swollen and thickened, it's important to use an infusion cannula which penetrates into the and avoid suprachoroidal infusion of fluid. Finally, we have silicone oil, which helps us avoid hypotony and manage many of the Next slide. The history of small surgery back in 1906, described in 2002 at the 25 gauge vitrectomy. That in 2005, 23 gauge conjunctival vitrectomy. And Oshima, 2010, introduced 27 vitrectomy. Today, I will emphasize the 27 gauge vitrectomy because this is a very nice technique in these cases to quickly enter the vitreous cavity and quickly perform a vitrectomy in these cases. It has the advantage of decreased operative time, less bleeding from the conjunctiva, less discomfort, and is a quick and simple procedure. Next slide, please. Here we see the setup for 27 gauge vitrectomy. In some cases, the infusion cannula 27 gauge does not come in a 6 millimeter cannula. So in some cases, you may have to use a 25 gauge infusion cannula in order to get the benefit of a 6 millimeter infusion. Next slide, please. I like to use the vitrectomy instrument with a sensor pad in order to obtain the initial specimen. This can be given to the microbiologist department for an immediate culture. Next slide. After that culture is obtained, we continue to remove as much of the formed vitreous as possible. This procedure should take approximately 10 minutes. It does not require blood compression with frequent inflammation and freezing the vitreous space, but rather at the core can remove the vitreous opacities. Next slide, please. 23 gauge is the technique that I have used in the past. You can see here obtaining specimen and a syringe of procedure. Next slide, please. Central vitrectomy performed. Slide. The eye is left soft at the end of vitrectomy in order to allow the infusion of the end of the procedure. These are
Dr. Flynn, sorry, the sound is not that good. Would you mind moving closer to the microphone, please?
Next slide, please. Our pharmacy prepares the intravitreal agents for us, You can see on the left vancomycin, 1 milligram. In the center, ceftazidime, 2.25 milligrams. And we use dexamethasone in cases of acute onset endophthalmitis after cataract surgery. Next slide. The alternative, excuse me, the alternative technique is to use a tap and inject. This series of slides in the upper left shows prepping the patient for a tap and inject, perivalvular anesthesia, placement of a speculum. I like to use a 23 gauge butterfly needle for this tap and inject, and I can usually find a liquid pocket of vitreous to aspirate, with this aspiration performed by my assistant until I see fluid in the line of the cannula. Next slide. A new alternative for tap and inject is to place the 6 millimeter cannula of a 25 gauge system into the pars plana and use that for aspiration. This is a technique we have tried, and it does allow more control without multiple needle entries for the injection of antibiotics and for the tap of the vitreous cavity. Next slide, please. This is a short video of 27 gauge vitrectomy. We could begin the video, please. This is a patient that developed Leb-associated endophthalmitis. You can see placement of the cannulas in a standard position. The instruments are introduced. In some cases, the hypopion will cover the intraocular lens and make view difficult of the posterior segment. We then perform a core vitrectomy. You can see the media opacities are cleared, and once the opacities are cleared, we exit the eye and inject the intravitreal antibiotics. Next slide, please. This is the patient prior to surgery and no visual acuity. But again, this is a very bad case, and I emphasize the fact that vitrectomy can be considered in these very bad cases. Notice the vitreous opacities in the upper right corner prior to surgery. After surgery, this glaucoma patient had clear media, the inflammation and involvement of the has disappeared, but visual acuity is limited by the pre-existing glaucoma to 200 visual acuity. Next slide. What about report on small gauge vitrectomy for endophthalmitis? There are actually not many reports, and we count on our colleagues at VRS to conduct future studies in a collaborative manner so we can have more experience. This paper was important because it showed in a in vitro study that silicone oil can reduce the growth of both bacteria and fungi. We know that clinically because it helps us in bad cases to achieve resolution of infection. Next slide, please. Here are two more papers on silicone oil in endophthalmitis. On the left, a study from Vietnam, randomized controlled study comparing vitrectomy with silicone oil versus vitrectomy alone. In this study, clearly silicone oil cases in this randomized study did better in terms of visual acuity and integrity of the globe compared to vitrectomy alone. Another study on the right, you can see vitrectomy and silicone oil for bad cases of endophthalmitis, often causing streptococcus, after intravitreal injections. In this case, many of these eyes have preservation of the globe. Slide, Finally, a study from China looking at silicone oil in post-traumatic endophthalmitis. These cases often have involvement of bacillus, and these cases tend to be most severe cases that we have to handle. So silicone oil is a great adjunct used in these very severe cases. Next slide, please. This is a case managed by me. This is an amazing case. This again is an endophthalmitis caused by glaucoma device. The other eye was no light perception. You can see the drainage device in the superior temporal quadrant and the severe endophthalmitis associated with the problem. In this case, we removed the glaucoma drainage device, and the eye was filled with silicone oil. The intravitreal antibiotics injected directly into the silicone oil. Full-strength antibiotics. We injected the vancomycin from the temporal side and the ceftazidime from the superior nasal side. These were injected directly to the silicone oil. And this patient had a miraculous return to 2000 the silicone oil remains in the eye. Many of these eyes, if glaucoma past, will have resolution of the high pressure because the inflammation of the infection damages the ciliary processes in the ciliary body to the extent that its production is. These eyes often have hypotony after treatment. Next slide. This is another study that was recently published in Journal Ophthalmic Surgery Laser. Together with my colleagues in India, we reported a large series of managed with silicone, either initially when there was a current attachment, or later when there was a delayed onset of attachment. Next slide. This slide summarizes the details of that study. On the left column, you see concurrent attachment in 20 cases, and on the delayed onset retinal detachment in these endophthalmitis cases. You can see that the factors, rates of complete retinal reattachment were relatively high. Visual outcomes were disappointing. With the concurrent retinal detachment group, only 30% achieved 2400 or better, and the delayed slightly higher, around 39% achieved 2400. Next slide. In the past, our group of Vascular reported our result of endophthalmitis and retinal detachment. These cases tend to be very severe cases. Our study found cases that involve streptococcus or more gram-negative organisms have uniform bad outcomes. However, this is caused by Streptococcus epidermidis, acnes, or fungi do much better. Next slide. I'll show a few examples of cases. This case on the left is presenting one day after cataract with severe progressive inflammation. You see on the right, vitrectomy, vitreal antibiotics, a good outcome, limited by cystoid acne. Next slide. This case of P. acnes endophthalmitis was chronic. Had a 6-month history of inflammation, and with vitrectomies and removal of the first capsule and the white black inside the capsule, the patient had a favorable outcome. Next slide. This is another case of chronic endophthalmitis with a progressive white black extending across the first aspect of the lens. And after vitrectomy and removal of Now, the patient had an outcome and long-term result without residual limbs. Here's another case that looked like pediatrics. It turned out to be a fetus. The organism was active functioning, and this case recurred and required removal of capsule and the bag and rocket in order to achieve resolution of the infection. Next slide. This is a case of the same case, lab-associated endophthalmitis. A vitrectomy was performed in this eye without removing the crystalline lens. Antibiotics were injected, the infection resolved, and later we cataract and intraocular lens. Slide. We published a series of these cases, 12 cases, with vacant status, and treated without removing the crystalline lens. The point of this paper was that vitrectomy or tap and inject can be performed without removal of uninvolved crystalline lens. Next slide. What about fungal endophthalmitis? Worldwide, we're seeing the opioid crisis with intravenous drug use. And you can see this case of involvement with cancer causing a retinitis, and following an injection after surgery, the outcome was this patient caused by cancer. Next slide. Again, another case. Continue to think about the opioid crisis and the value of vitrectomy and diagnosis and treatment of this condition. This patient had a favorable outcome with vitrectomy and vitreal injection. Yes. Next slide. I will change my final slides to summarize the problem of emerging resistance to antimicrobials and the choices for treatment of these cases. This paper was published in the last few months in the journal Retina and is available with all the tables in that publication. Next slide. Our first line treatment with antimicrobial are shown on this slide. Antibiotics are listed at the top, and pink vancomycin 1 milligram for empiric gram-positive organisms. Ceftazidime 2.25 with coverage of gram-negative organisms. The alternative agent is casein 0.4 milligrams for alternative coverage. Antifungals, amphotericin is the traditional approach. The more recently reviewed conazole have shown superior results with conazole coverage of holes such as myces, which are particularly difficult to treat. Next slide. The alternative agents for coverage on positive organisms are limited. Linezolid is one agent. There is very little experience with that. Daptomycin is another agent. Sinucid is another. However, there are a few case reports using agents that this requires further. Next slide. As far as gram-negative organisms, friend is imipenem, and there's a large series here using 50 micrograms in humans, primarily in cases of tetanus. These cases were resistant to ceftazidime and casein. Keep in mind that ceftriaxone and ceftriaxone do not cover Pseudomonas, and therefore cannot use. Next slide. Fungi, there are some limited reports of using conazole We have a very experienced those at this time. Next slide. So in conclusion, I'm very honored and privileged to be able to Relja lecture today. I appreciate this award from Europe, throughout the world. Look forward to seeing you perhaps at the next meeting. And thank you again for this wonderful honor.
Thank you so much. We appreciate very much your effort into giving us this wonderful lecture at such a distance, and we truly do hope that we will be seeing you in Europe soon to share the pleasure of your company. Now we would like to present you the award, at least symbolically. We will then mail it to you, and Şengül is going to present the Zivojnovic Award to Harry Flynn.
Thank you very much.
Harry, can you see it? Can you see the award?
See you. Thank you very
Good.
much.
Okay, great. Thank you so much. Thank you for giving us your time. Thank you very much.